Good evening, everyone. This is Dr. Perry Maynard with Integrated Health Systems. In tonight's presentation, as you can see, ASCVD risk or atherosclerotic cardiovascular disease risk. So really, today is going to be discussing cardiovascular disease. And my goal today is to shine the light on a little bit more than just kind of the typical risk factors that individuals discuss, right? We will discuss those, so things like lipids, and I hope to give a little bit greater understanding behind lipids, far beyond LDL and blood pressure and things like that, but talk about other systems and other things that can also contribute to cardiovascular disease, or like you'll see, a lot of them end up increasing some of those main risk factors that we're going to talk about as well. So today, my hope is that individuals feel a little bit more educated on this topic, what things to ask their doctor, what kind of testing to look for. We'll talk a little bit more about some advanced testing at the end. Really, I mean, just one of these topics I'm going to talk about tonight could be a whole evening talk. So I realize that, so I'm trying to give a lot of information in a small period of time. If everyone is interested in learning more on one of these topics, let me know, and I'm happy to do a webinar on that topic as well. Perfect. So if we look at here, right, so if anyone were to do a Google search or chat with any doctor, you would see there's really three big risk factors that individuals talk about. And in a second, we're going to go into depth into a more complex web that is ASCVD. Right, so you can see here some of the top main risk factors, right, are smoking, blood pressure, and lipids, right? And we're not going to talk a ton about smoking. That's pretty self-evident at this point. And really the best way to avoid that risk factor is to stop smoking, right? And the best time to do that as soon as you pick up a cigarette. Now, I realize that's easier said than done, so this is not a discussion on how to stop cigarette smoking, but we know that smoking increases risk because of the increase in inflammation, but with how damaging it is to the intimal layers of the vascular system, right? But we will talk a little bit more on blood pressure. We'll talk a little bit more on the new guidelines on blood pressures. We're going to go a little bit more in depth into lipids as well, so you have a little bit a better understanding of some better markers that some would argue are maybe a little bit better than LDL cholesterol, which we traditionally use. And then I want to get into discussing more of the web of cardiovascular disease. This is looking at the gut's role. This is looking at the brain's role, insulin's role, thyroid function, sex hormones, and fat cells. So looking into how all of these play an interplay into the development and the worsening of cardiovascular disease. So before we get too in-depth, let's talk a little bit about what happens in cardiovascular disease, or to the best of our knowledge, what is the pathophysiology? What is really occurring when we discuss ASCVD? So if we're looking at an artery, right? So within an artery, we have multiple layers. We have a tuna, intima, media, and externa, right? And so the intima is what's really relevant when we are talking about cardiovascular disease, because that's what can become affected. So if we look here to the left, you'll see a kind of a stepwise progression of what occurs. And on the right is a picture that I love that we use quite often that kind of shows the progression of this process. But what's cool about it is it shows you different markers that are relative to that, which we'll get into a little bit. This is from a great lab called Cleveland Heart Lab that really kind of gives you all of these markers. So it gives you a window of the progression of something like ASCVD, so you can try to catch things early to try to be preventative, right? As we know, cardiovascular disease is one of the leading causes of death. You know, we spend so much time sometimes talking about, you know, some of these random diseases that we may or may not get, but at the end of the day, odds are that, you know, cardiovascular disease is probably what will take us out, right? And it's highly modifiable and it's highly preventative, you know, with lifestyle modifications, medications, supplements, things like that. If we are looking at the pathophysiology, so one of the first things is damage to the inside of the artery, or the tuna intima. And this is a big reason why blood pressure is such a big thing. This is a big thing why smoking is such a big thing, is if we look at something like elevated blood pressure over a long period of time, is that damages the inner lining of an artery wall. And that sets up this concept of vascular permeability, but also the ability for things like lipids, most specifically LDL, along with some other atherogenic particles that we'll discuss in a second, things like VLDL and IDL. These are some other forms of carrying molecules, but then they can get caught within that intimal layer, right? And so from that point on, when these things get trapped in the intimal layer, they trigger an immune response. And that immune response is what starts to lead to things like fatty streaks and eventually the formation of plaques, right? And the concerns, we can see here, oxidation of LDL, that's the immune system coming in, reacting to the LDL particle being stuck in the inner lining of the artery. We get platelet aggregation of the injured, right? So it's kind of a sign that there's injury to the artery, and ultimately thrombus formation. And this is occurring, right? So we get narrowing or stenosis of the artery. So this limits blood flow. We can have occasions where these break loose. And this can lead to pulmonary embolisms or strokes, things like that, where all of a sudden we dislodge a plaque formation and then they get caught somewhere else. And this can lead to severe impairment and even death. And so this is a really, really important thing that we discuss. And even just the narrowing itself is not great. You know, this is where you see these things happen over decades and decades. I mean, there's some autopsy studies looking at children, looking at teenagers, already seeing the presence of atherosclerotic cardiovascular disease or on the way there. And so these are not things that just start in your 40s, 50s, and 60s. These are things starting much, much earlier. And this is why I'm going to make the argument, the earlier we can intervene and the more we can assess risk, you know, I think some will argue we could significantly lower the burden that is cardiovascular disease on society. So let's talk a little bit about cholesterol. You know, as we know, you have HDL or high density lipoprotein and LDL, right? The bad cholesterol. But what are these things? So if we think about cholesterol, right? Cholesterol is necessary for life. So cholesterol plays a huge role. It is in our cell membrane. So if we think way back to, you know, biology classes, you know, that we took back in high school or even college, right? Within that cell membrane, it needs to be fluid. So we don't want it to be too rigid and we don't want it to be too fluid. We want it to be just the right consistency. And so we know we have cholesterol particles scattered all throughout, and cholesterol plays a huge role in production of hormones, right? We know without cholesterol, we would die. One of the problems is, though, that cholesterol is, we'll just say, scared of water, right? And so it doesn't really mix well, very, very well with water. And so we need a carrying molecule to take it from one tissue to another tissue, okay? And this is where lipoproteins come into play. So think of lipoproteins as carrying molecules of cholesterol. So when we look at something like HDL, that is high density lipoprotein, okay? And then we have low density lipoprotein. And then as you'll see in a second, we have intermediate density lipoprotein, and then we have very low dense lipoprotein, or these are VLDLs. And so, you know, cholesterol has always been demonized, but as you have more and more data coming out, it's not as much the cholesterol as it is the particle count or the amount of carrying molecules in, if that makes sense. So an LDL particle is like a boat and it's carrying cholesterol. So when you usually get your standard cholesterol panel, depending on what it's looking at, most of the time it is looking at the amount of cholesterol within an LDL particle. And this is why there is some debate, is that the best marker, right? Because it's not as much the amount of cholesterol within an LDL particle versus the actual amount of LDL particles within the bloodstream. Or to say it differently, is that things like LDL, IDL, and VLDL, like we'll chat about in just a second, it is the exposure to higher amounts of those particles over time that does appear to actually be an independent risk factor for cardiovascular disease. Now, you're going to have different camps get up into arms. You know, you're going to have the alternative world get up into arms and say it's more complex than cholesterol. And I will agree with you. And then you might have the other side where this is the only metric, right? And there's more to the story, but to say that particles and lipids don't play a role in cardiovascular disease is definitely not true, right? The science supports that particle count, or more specific marker, what we're going to talk about in a second, called ApoB, does appear to be an independent risk factor, in that the higher that number is over time, increases your odds of this event happening, right? And if you think about this makes sense. If within an artery, there's damage over time, and we know that at the pathophysiology level, it is those ships or those LDL particles that can get caught. Well, if you have 10 versus 1,000, right, the odds of it getting trapped somewhere is much greater if you have 1,000 versus 10. And then you layer that on top of something like smoking, drinking, high blood pressure, and some of these other things. That's where you kind of see this triad of really increasing risk of something to damage, and then the particle that is kind of at the backbone getting caught, then you have higher amounts of that. Right? We still need inflammation. We still need all these other things. And that's where that bigger web is going to come into play. So this is where we look at something called ApoB, or apolipoprotein B, okay? And like I said, there's a growing body of evidence that is starting to look more at ApoB levels as possibly a better indicator of cardiovascular risk than just LDL. So ApoB is a protein that sits on the outside of atherogenic particles. These are, as you can see, very low density lipoproteins, or VLDLs, IDLs, chylomicrons, and LDLs. And so ApoB gives you a picture of all atherogenic particles. And this is different, right? This is not measuring how much cholesterol is within a ship. It's saying how many ships are there. And so you can look at something like LDL particle count, right? And we do this quite often. But with that, you're going to miss IDLs and VLDLs. So you're going to miss some more of the molecules associated. So ApoB gives you a little bit more of a comprehensive view of saying how high of an amount of atherogenic particles do you have present, right? So this is growing to become a better indicator and marker used compared to LDL cholesterol, right? And even total cholesterol. There's pieces to that are important, but something like ApoB is going to be a little bit more indicative of cardiovascular risk as it relates to lipids. Let's talk a little bit about blood pressure. And like I said, we could spend a whole thing on blood pressure, what to do about it. And if individuals would like that, I'd be happy to do that. There's so much complexity of blood pressure with neurology in the brain, and it's not, always as simple as necessarily more salt, less salt, things like that. But we do know that there are new guidelines. So there are new guidelines that came out recently and a new consensus, and we'll talk about how they measure blood pressure, because that's an important piece to make sure that people are measuring blood pressure in an appropriate way. And the best way we can do that is to match that up with the consensus that was done recently. As you can see here, they've gotten even stricter, right? So normal is now less than 120 over 80, elevated 120 to 129 over 80. And then you can see stage 1 hypertension is now between 130, 139 and 80, 89. You can see so on and so forth. So they've kind of bumped it down like 10 points. It used to be that stage 1, I'm pretty sure, was 140. So they've gotten a little bit more strict with that. And when you're looking at blood pressure, I think this is something everyone should have a good idea. Everyone should have a monitor at home. Yes, the best way to measure blood pressure is manually, but it's not necessary. And if you don't have a trained healthcare provider who can do that, there's great electronic ones. We use Omron. There's no financial association with them. That's just what we use. So Omron are good cuffs. And when you look at the new consensus, what it looks at is an individual is seated in a quiet room, not distracted, right? Not on their phone, no music, nothing around, and sitting for 5 minutes upright, legs not crossed, and then taking a reading of blood pressure, and then waiting another 5 minutes and another reading, and then another 5 minutes. So 3 measurements over 15-minute period is kind of what the consensus used to start to determine their new metrics. And so now, does everyone have 15 minutes to do that all the time? But I think it'd be really good. And I tell my patients sometimes when there is concern is, maybe every few months you check in, and for 2 to 3 days, you find a period where you can do something like that. Even if it's just 2 readings where you're sitting quiet, relaxed, away from stimulants, away from these different things, and just getting a good baseline of where you're at, right? And this is important because so many times we're getting our blood pressure read, where we are going to the doctor, we're in traffic, we've been stressed, we sit down, a lot of times it's not even taken correctly. And so we might be getting these artificially inflated numbers. And so we really want to get an accurate number because blood pressure does fluctuate, right? Blood pressure fluctuates. If you were to ever look at your blood pressure while weightlifting, you would think you might be having a massive stroke, but that's a normal thing to occur. We want to see what it is at rest because we know it fluctuates. One of the gold standards is what is called a 24-hour ambulatory blood pressure monitor. And this is used sometimes in hypertension, where it's literally a 24/7 reading of blood pressure. And this can give you a really good idea of what's going on. But blood pressure is something that a lot of times can be very modifiable with diet and lifestyle and stress management. Like I said, for those of you who have watched my dysautonomia series, you'll realize that the brain has such an important role on blood pressure and heart rate, right? Our anxiety networks, our limbic and emotional centers play a huge role in regulating these different things. So let's get into the web, right? Everyone's probably familiar with blood pressure, lipids, probably boring for a lot of people. So let's talk about something that not as many individuals may be aware of. And so this is the web. So let's talk about the gastrointestinal system or the GI tract. Now, everything I'm going to talk about is not everything that's out there. These are just going to be high points. So if I leave something out, please forgive me. These are just going to be some things that we pay attention to clinically. And so when you look at the two big things, microbiome dysfunction and dysbiosis metabolites, these things can influence cardiovascular health. And they can do it via modulation of blood pressure, but also arterial health. So you can start to see the health of your gut and the things you eat can indirectly affect blood pressure and vascular health via certain metabolites. So we know that things like intestinal permeability or leaky gut promote inflammation. But when we look at metabolites, one of the more specific ones is something called TMAO. And you might have heard some talk about it. You hear the vegan side, the vegan and vegetarian side of the argument, use this argument quite a bit against red meat consumption, things like that. And they're not wrong. When we look at TMAO, as you see in the picture, is a byproduct of dietary choline and carnitine production, right? Which largely comes from things like red meat. And some of the things that, scientists are working on discovering is, right, something about choline and carnitine and the way they react within certain microbes in the gut. And usually it's in a gut that has dysbiosis. So in a healthy gut, it doesn't appear to be as bad as in an unhealthy gut. We can see that there's the presence or the production of the TMAO. And when you look at the TMAO, you can see there is correlations with that and kidney fibrosis and kidney disease, heart failure, atherosclerosis and vascular inflammation, and thrombus formation, right? But the cool thing is this can be tested, and I test this on myself as well. So, if you are concerned of one of the risk factors of increased meat consumption and its role, you can look at things like TMAO. And there are all sorts of ways to assess it and then ways of treating to try to mitigate TMAO levels, whether that is making sure you have healthy kidney function, because this should be freely excreted by the kidneys. So sometimes if individuals have issues in their kidneys, this may build and things like that. So TMAO is a kind of a newer marker that we are looking at as a metabolite from a dysbiosis in the gut. And that in turn can increase risk of cardiovascular disease. And then we also know that the gut plays a huge role in cholesterol metabolism. And then there's also IDO, which also plays a role in inflammation. The next thing we're going to look at is insulin and insulin's role in cardiovascular disease. We know that things like type 2 diabetes increases your risk really of all-cause mortality. Things that have to do with elevated blood sugar and diabetes are just not good for any health metric. So when we look at things like insulin resistance, we know that this can increase estrogen in males and testosterone in females. And when we get to sex hormones, this is not the best thing for cardiovascular risk. The increase in advanced glycation end products, or in essence, sugar binding to proteins throughout the bloodstream, can create vascular damage. Things like increased fat accumulation, will promote the production of more inflammatory cytokines. So we know individuals with insulin resistance tend to be more obese, and obesity, we have more fat cells, we have more fat in our fat cells, and we get unhealthy fat cells. And like we'll talk about when we get to fat is not bad, but we can have unhealthy fat, and that can be pro-inflammatory, and that can secrete things like interleukin-6 and other inflammatory cytokines. Right, and this is when you look at COVID, where we can see that obesity was a risk factor because individuals were already primed. They're already primed with too much inflammatory cytokines. So that kind of became the straw that broke the camel's back. And then things like increased aldosterone, which aldosterone plays a role in fluid retention in the kidneys, and this can increase blood pressure. Once again, this list is not everything. There are far deeper and more reasons why insulin resistance can create cardiovascular disease, but these are just some of the main ones. So understanding your insulin sensitivity, understanding things like your hemoglobin A1C, your fasting glucose, right? Making sure you have as healthy as possible glucose levels will in turn lower your risk of cardiovascular disease. Thyroid, right? So thyroid is not something that's talked about heavily, but thyroid plays a huge role in prevention or having a healthy cardiovascular system. So it plays a role in clearance of cholesterol. Most specifically, it plays a huge role in maintaining healthy endothelial nitric oxide levels. So nitric oxide plays a huge role in dilation of blood vessels. So making blood vessels nice and fluid and being able to dilate and move blood around. As we get things like cardiovascular disease, our arteries become very stiff and hard. And they don't fluctuate and move very well, and it becomes very hard to bring tissues nutrients. And this is why individuals with cardiovascular disease are fatigued and have brain fog, and they don't heal well, and they have wounds that don't heal because they're not able to get blood flow to areas because their arteries are not healthy and they don't have healthy nitric oxide levels. And then also the promotion of angiogenesis, growth of new blood vessels, and then promotes appropriate cardiac mitochondrial function. Now, as you can see to the chart next to me, this is a chart on hypothyroidism and its role in cardiovascular disease. But hyper or high thyroid also can affect the heart. So you can see here, hyperlipidemia, oxidative stress. It affects peripheral vasculature and endothelial dysfunction. So this chart really kind of summarizes up the points that we had stated. Having appropriate thyroid levels is really important. So this goes back to understanding, do you have hypothyroidism? Do you have hyperthyroidism? Do you have something like Hashimoto's? In getting that treated, whether that be naturally or whether that be with medication, is really important if we are wanting to lower our risk of cardiovascular disease. Sex hormones, right? So these are things like estrogen and testosterone. We're going to talk about specifically, not as much progesterone, things like that. So mostly estrogen and testosterone. So in females, we know that decreased estrogen can increase cardiovascular risk, and decreased testosterone in males can increase cardiovascular risk. So this is why, when we look at postmenopausal women and we look at risk for all sorts of things. So if we look here at this chart, so traditional risk factors, age, hypertension, dyslipidemia, smoking, inactivity, and then female specific risk factors, things like autoimmune disease, polycystic ovarian syndrome, which in essence is excessive androgen. So in PCOS, one of the problems is we have increase in androgens, things like testosterone, breast cancer treatment, pregnancy complications, depression, hormonal therapy, right? So hormones do play a very big role. So it's very important to be working with your doctor or your OBGYN and making sure that depending on your age range and where you are in life, that you are supporting hormone production, whether that is naturally or whether that is with something like bioidentical hormones. Making sure that those are dialed in is really important. As you can see here, they play a role in increasing plaque stability. So when they're off, plaque can become more unstable. It increases the risk for oxidation of LDL. So when those particles get caught in an artery, increases the odds of the immune system attacking them. Dysfunction to the endothelial nitric oxide, so your ability to modulate blood pressure, and then vascular inflammation. Adipocytes, right? So these are fat cells. So we always talk about fat as being bad, but fat can actually secrete certain things or certain immune signaling molecules that actually can be anti-inflammatory. And this is specifically what adiponectin is. So adiponectin is produced by healthy fat cells, and it actually is anti-inflammatory. It plays a role in modulating the immune system and actually decreasing risk of cardiovascular disease. But when we have things like insulin resistance and obesity, and these things get out of control, we have decreases in adiponectin, right? And so this leads to more of a pro-inflammatory state out of fat cells. And then we have things, increased activation of PL2, which can play a role in clot formation, increases in systemic inflammation, decreases in a marker called vascular endothelial growth factor, which plays a role in angiogenesis, and a decrease in endothelial nitric oxide dysfunction, right? And this is where individuals lose weight and their blood pressure gets better, right? That's for a multitude of reasons, but one is also the pro-inflammatory state of fat cells. This is where we can see that all of these ultimately come back to increasing risk factors because they affect blood pressure, they affect lipids, they affect inflammation. So it still comes back to the basic risk factors, but it's saying there's more than maybe just a statin, and there's more than just maybe blood pressure management. This is really looking at getting to the root. It doesn't say that those things don't have utility and validity. They do, but this is a little bit more of a root cause analysis of what are the things driving dyslipidemia? What are the things driving hypertension? What are the things driving vascular inflammation? We have to look deeper into these pathways. And then lastly is the brain. And for those of you who follow us, I have done quite a bit of webinars on dysautonomia. Dysautonomia is dysfunction of the autonomic nervous system. This is when that system fails, right? And this creates conditions like vasovagal syncope, postural orthostatic tachycardia syndrome, neurogenic orthostatic hypotension, conditions like that. But it also plays a role in vascular health and blood pressure. So an individual doesn't have to have true diagnostic dysautonomia, but this is just to say that the healthier our brain works, the better we can regulate blood pressure and autonomics. So like I said, blood pressure is heavily influenced by our brain, right? We have all sorts of reflexes, everything from our sleep-wake cycles to our arousal centers, to our limbic emotional and anxiety centers, all the way up to our prefrontal cortex, all play a role in blood pressure management. And so we try to take a deep look at individuals' neurology to understand how might that be influencing vascular health and their risk for things like cardiovascular disease. And we have a variety of different tests we can look at. This is an autonomic nervous system test that we do. This is kind of standard autonomic testing. This where we look at things like a tilt table, hand grip test, Valsalva deep breathing. Hand grip actually is a pretty cool test when we look at things like hypertension. So when we look at hypertension, a hand grip test where you take a dynamometer and you squeeze it at 30% of your max and you look at how your blood pressure responds can be a predictor of hypertension, right? And we won't get into the depth of it, but it can be a really cool test looking at hypertension risk. And like I said, we know that hypertension is one of the leading drivers of cardiovascular disease. So if we look at some lab markers, and once again, there's some more than that are on this list, but this is a pretty good place to start. Something like a CBC or a complete blood count, comprehensive metabolic panel, an advanced lipid panel with something like ApoB. So I think getting something far beyond just total cholesterol, LDL, HDL, triglycerides, those are important. But I like looking at ApoB with that, or more specifically, Cleveland Heart Lab has even more advanced lipid markers, but it also looks at a variety of inflammatory, so things like F2 isoprostane, which is an early marker of oxidative stress. It looks at oxidated LDL, right, all the way up to things like LPPLA2, which is a plaquing marker. So you can kind of look at, is there early signs of, early signs of inflammation? Are there signs of plaquing? Are there signs of unstable plaquing? Are there signs of like ischemia and heart attack and things like that, right? So it kind of gives you that spectrum. But then on top of that, you can look at things like ApoB and particle count. So you can look at everything from the early on risk factors all the way to end stage things and even things like kidney disease and kidney failure. So it's a really cool lab, and it's relatively cost effective and relatively affordable. And I love that panel for getting an idea of risk factor. And then also success with treatment as well. Hormone panel, so full male or female hormone panel. Things like fasting insulin and A1C. There's a lot of other blood sugar markers that can be looked at, but those are some standard ones. And then something like a thyroid panel. That's a really good place to start. You can look at things like adiponectin, and you can get pretty detailed pretty quickly, but this alone for most individuals will be a great place to start to really understand risk and then understand maybe what treatments we need to look at. And this is important because this is where individuals may benefit really well from diet and lifestyle changes versus there's some individuals that need medication, right? But we have to look at these things to understand where a person sits, and then also maybe how they respond to diet and exercise. If they're responding well, then great. If not, then that's where we might need to look at things like medications to further lower their risk. When we look at other tests that we really like, things like echocardiogram looks at more the structure of the heart, how the muscles are working, kind of like the output of the heart, how much blood is it pumping out. So it really gives you a good window into the function of the heart. And then something like a ECG that looks more at the electrical activity of the heart. And then two other ones, a calcium score, which is really cheap. It's really affordable. It's very easy to do. It's relatively safe. There's not a ton of radiation from it. This can give you what's called your calcium score, which can give you a window into cardiovascular risk. What's even more accurate and a little bit more sensitive is a CT angiogram. So a CT angiogram gives you even earlier signs of fatty deposit and streaks. And then there's what's called the ankle brachial index and peripheral artery examination. So we have some testing where we can look at the health of peripheral arteries to start to pick up, is there signs of peripheral artery disease? And so really, if you have an individual and you take a good detailed history and physical examination, and then that's layered on top of some of those labs we talked about, and then something like a calcium artery score or a CT angiogram, you got a pretty good window of what is their risk? What is their risk in the next 5, 10 years, and so on and so forth, and how are they responding to care? I run these on myself quite often. Even though I'm younger, I look at something like a calcium score just to see where I'm at. And I look at it every so often because I want to pick things up as soon as there's the slightest little sign. I don't want to wait till I'm in end stage kidney disease or, God forbid, a heart attack or a stroke, and so I want to do everything in my power, and I want to do everything in my patient's power to try to lower the risk that will happen, right? Because when you look at, what are some of the first symptoms and signs of a heart attack, they're death. It's gotten better, but unfortunately still too large of a population. The first heart attack is the last heart attack, right? And we want to try to avoid that. And we want to try to see this coming from 1,000 miles away so that we can move away from this train that is ASCVD. So my conclusion, act sooner rather than later. Like I said, too soon, you can't be too soon, I think, in some of these things. I mean, do you need to be running these in teenagers and 20-year-olds? No. But I think, for myself in the 30s and individuals, in their 30s, early 40s, I don't think that is too soon to start getting a window to say, what is your risk factor? And then when you choose dietary interventions, supplements, medications, exercise, you have metrics, you know what to work on, and you know what to challenge your treatment against. Is it successful, right? And it's never too late, right, to reach out. We offer free consultations, and during this time, we can have a good idea if we think we'd be a good fit with a patient, or if we can find a good provider for you in your area, depending where you're at. We work with individuals all around the country. We do offer telehealth, especially with things like this. A lot can be done from far away. And yeah, so we are integrated health systems and integrated brain centers. If you're interested in a consultation for you or a loved one, that is our number. Like I said, if you want to learn more on one of these other topics, please let us know, and we'd be happy to put out more educational content on any of these different topics. My hope is just to empower individuals to take health into their own hands and to be able to be well informed when they're going to the doctor, challenge their doctor, ask questions. When I say challenge, doesn't mean you have to be combative, but it's okay to push, to press. It's your health, it's your body. And doctors should be open to educating and explaining kind of why they're doing what they're doing. So I hope everyone has a great evening. Thank you so much for joining.